Hi, everyone, and welcome to this month's Leong Center Trainee Hub event. My name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist here at the Edwin S.H. Leong Center for Healthy Children, as well as your moderator for the series. I'm incredibly excited to introduce both of our speakers for today's session. We're joined by Saskia Kwan, who's the co-founder of Amplify Engagement, where she designs and leads meaningful engagements that bring together diverse perspectives. She's worked in brain health, education, and evaluation, and is passionate about building relationships and making spaces accessible for everyone. We're also joined by a second speaker, Jenine Paul, who's the co-founder of Amplify Engagement and has led community engagement work in research, policy, and healthcare for over a decade. She previously managed public engagement at ICES and helped shape an anti-racist research agenda to ensure that racialized communities inform data governance and use. Janine's also a skilled facilitator who's passionate about embedding community voices in decision making. So, to anchor us, today's session shares practical ways to include community engagement and knowledge translation at each stage of the research process, from identifying research questions to interpreting data. So, I'll pass it over now to our speakers so that they can take it away.
Thank you so much, Priscilla. Thanks everyone for joining us. We're glad to be here and we're looking forward to a presentation that we've prepared and then questions and discussions from you all. Perfect. We are Saskia and Jenine. Thank you, Priscilla, for those introductions. I don't think we have to talk too much more about ourselves, but just briefly, we 3.5 years ago founded Amplify Engagement. Amplify Engagement provides public and patient engagement and knowledge translation services all across Canada in health, research, and public policy sectors. So we work with researchers, research teams, universities, hospitals, nonprofits, governments, to help them collaborate with their communities, with their patients, with their stakeholders, and help them share their findings from research. So that could be anything from designing research engagement plans to knowledge translation plans to facilitating meetings and workshops. And so we're excited to share some of what we've learned over the many years that we've been doing this and how you can as well integrate, hopefully, some of this work into your research. So just quickly before we get underway, we'd love to see who is in this virtual room today. So if you could share in the chat your name and your role, very briefly, your research project area of focus, and then because of tomorrow, your favorite Halloween candy. And maybe while people start typing, my favorite Halloween candy is, I think it'll have to be a Kit Kat bar. It was always a good one. And Jenine, while we wait, oh, she already wrote it. Perfect. Jenine loves Skittles.
Sour Skittles.
Sorry.
Sour Skittles.
Who else do we have in the room? Please feel free to say hello. Hi, Andy. Thanks for joining from the Leong Center. And she loves Wonder Bars. I don't know if I've had a Wonder Bar in a long time. Only Halloween Wonder Bars. Are those special kinds of Wonder Bars? Who else do we have here? Anything from Shelby, Selena, there's Tiffany, there's Vicky, Yola, Benjamin, welcome. I think everyone can read for themselves the good stuff, but I'm just going to highlight the candy here because, it's Halloween. Crunch bars. I don't even know what those are.
The blue wrapper. Those are definitely
yes.
only Halloween. That's a good one, Benjamin.
Okay. Selena loves Sour Patch Kids. Thank you. Emily loves anything chocolate. Vicky is a fan of Twix. Tiffany, welcome. Loves Sour Peaches. We've got Team Chocolate and we've got Team Sour Candy. Nina can't decide. Nina loves it all. Carolyn, thank you. You joined the Kit Kat team with me. Nice to meet you. Hi, Yola. Team Arrow for Yola. Shelby loves some Reese's. All sorts of variations of those, eh? Welcome, Fatima. She loves M&Ms. And Katiel, I hope I pronounced that right, loves chocolate. Okay, we've got Team Sour and Team Chocolate mostly. Glad to be in good company of everyone who loves things sweet. We'll get underway and feel free to read and see who's in the room with you. So for today, we are we're going to do a refresh just to make sure we're all on the same page of what is community engagement and what is knowledge translation in research. And then the bulk of what we want to talk about is how you can do engagement and knowledge translation throughout the research process at various different stages of research, from designing research all the way to collecting data, to analyzing data, to dissemination. You can involve people, community, patients in each of those stages, and we are going to walk through different examples today of how that can be. And then finally, we have some considerations for meaningful engagement. So thinking about very specific stakeholders and how you want to include them in your research. We have some sort of 101 tips to get you started with that. And then I guess, of course, we welcome questions and any discussion at the end. So feel free to hold your questions till the end, or you can pop them in the chat if they come up for you during the conversation. So before we dive into definitions, we just want to understand everyone's baseline knowledge of community engagement and knowledge translation. So we have a poll for you if you can participate. The question is, how familiar are you with knowledge translation? You are familiar and have done KT as part of your research. You are familiar with KT as a concept, but haven't done any activities. You've heard of KT. It's a term that's going around often, but you're not exactly sure what it means. And you are not familiar with KT at all. You have not heard of it, really. All right, so we have about half and half almost. Half have had the chance to participate and do KT activities, and the other half are familiar but have not done KT activities. So welcome. Hopefully this is relevant for both these groups, those who have never done it and those who have. What we find is often people have done knowledge translation activities more towards the end of the research process in the dissemination phases. And so we hope this presentation can give you some new ideas of how to do KT in other steps as well. And just very quickly, the second question we have is with community engagement now. They're similar, overlapping yet distinct terms. So we're just curious with how familiar are you? Familiar and have engaged community, familiar but have not engaged community. You've heard of community engagement but not confident what it means, or you have not heard of community engagement. Okay, so we have about half who, I think I have to end poll to share. Perfect. Half who are familiar with community engagement and have done it, and then a mix, about 1/4 who have heard of it but never engaged community, and 1/4 who have heard of it but aren't confident in what it means. So you're all in the right place, hopefully. And again, we'll talk through how to engage community and some tips we have for that. So the definition of knowledge translation, this is from CIHR and it's been adapted, but it is the iterative process that includes synthesis, dissemination, exchange, and application of knowledge to improve the health of Canadians. So those four, that's a lot to unpack in those words, but the synthesis is, the aggregation of data and research and knowledge. The dissemination is, pushing out that knowledge, the exchange amongst different types of stakeholders in different sectors, and then the application of knowledge. So what behavior, what practices have to change in order to use this knowledge in everyday life. Those are sort of the four big pillars, let's say, of knowledge translation. The term integrated knowledge translation is also a term that's been used often in research now. And this means that the stakeholders or the research knowledge users are engaged in the entire research process. So it's not just that you engage people at the end of your research process, but throughout the research process. That's what we refer to when we talk about IKT, or integrated knowledge translation. Patient engagement in research is when you meaningfully collaborate with patients. So patients become not just the subjects of your research, but they become true patient partners in the project. And you can actively engage them in governance, in priority setting, in developing research questions, in performing parts of the research itself, or in summarizing and sharing the research. So this, again, the distinction of patient engagement versus patient as a subject is that they become partners in the research and are part of different stages of the research process. And we'll get into more of that. And then a quick note, we talk a lot about patient engagement, and then there's also talk of community engagement. We're going to use them interchangeably for the sake of this presentation. Often patients nowadays refer to more broadly the caregivers and those involved in the care of that disease. And so community engagement has been used more and more for a more broad term that includes any group of individuals who are close or interested or affected by the issue or the topic or the research. So this can be, more traditionally like a patient definition of people who live with the experience of a disease or a disorder, but it can also be people who live in a neighborhood. It can be a certain cultural or ethnocultural group. It can be an age group such as seniors or youth, or it can be a professional group. It can be policymakers, it can be teachers, it can be researchers even. And so thinking about broadly community engagement is really involving anyone non-academic who has a close interest to the issue and can be impacted by that issue. So I think we'll interchange them for this presentation, but mostly we try and say community engagement just to be more broad and inclusive of all sorts of individuals who should be engaged in research. And so the last sort of theory, that definition we wanted to present when it comes to community engagement is a spectrum called the IAP2 spectrum of public participation. It's a mouthful. There's a link there if you want to look at it later on. This framework was put out by a group called the International Association of Public Participation, and it explains how you can involve community, you can involve patients, you can involve members at different levels of participation. So starting from inform, which is just the very lowest touch way of involving a community member. You can inform them of the project. You can inform them of the knowledge and information that you have. To the next step, which is consult. And consulting is where you're more involving of the community members. So you want their feedback. You are sharing some of the decision making. To the next step, which is involve. Involving is really getting more partnership with community members and research partners. You're involving them in decision making and you're making sure that their feedback's being considered. The fourth step on this scale would be collaborate, where you're really patient partners, community partners, and research partners are all coming together to share all decisions of all the power of decision making. And the final step would be empower, where you really give the power of decision making over to the community, over to the public, over to patients, and you release that power from the research, from the researchers themselves. So the spectrum, it helps set expectations for everyone of how you want someone to be involved and at what level their involvement will be. It's not necessarily that, involve is the worst form of engagement and empower is the best form of engagement. It's really about right-sizing how involved you want someone to be and then managing those expectations and making sure that everyone understands what their role is in the project. So as long as you're clear on what kind of involvement, what kind of feedback you want, any step is a great step for engagement. Okay, so the rest of the presentation, we really want to dive into this research process, which as you are all researchers, we don't have to touch too much on what the research process is, but what we want to focus on is how to embed engagement and knowledge translation in each of these steps. So you will be familiar with the many steps of the research process, starting with identifying and prioritizing. Jenine will walk through some examples shortly, but there has been a big movement to involve patients and community members into actually helping decide what is most important to research and what are the questions we want to be asking. Then in the research design, we are also often involving research community members into helping design the research itself. So what should it look like? How should data be collected? And the decisions that need to be made on the design of the research. In the third step of the research process in grants and funding applications, community members more and more are being involved in helping put those together, helping inform how those applications go in, helping inform what funding sources you want to go for. And so they can become great partners in that funding granting stage as well. In the fourth stage in data collection, more and more we see community members being able to influence how data should be collected, especially when data collection is happening from people who, maybe, for example, are living with a certain disease or disorder. People with knowledge and lived experience of that disease or disorder can really help inform how data should be collected. In data analysis and interpretation, we're seeing more and more that research really is leaning on people with lived experience, community members, to help provide context to the data. As people who live with the experiences that you're researching, they really provide a lens and an understanding to the numbers, to the data that you're collecting, that often researchers aren't able to provide if they don't have that lived experience. The most common, I would say, process step for involving community and patient members is dissemination. So this is the most common knowledge translation and patient engagement happening. So once you have knowledge from your project, from your research, patients and community members help package that knowledge. What does it look like? What form should that look like? And who should be getting this knowledge? What community members, what users, knowledge users should receive this knowledge, and what should they do with it? And then finally, there's implementation and evaluation. So that's how do we use that knowledge? How do we implement it to change a behavior, to change practice, to change policy? What needs to be changed? How do we change it? And then how do we make sure we're evaluating it so that we're actually getting the changes that we hope for from the knowledge that we've generated from research? So that's overall the research process. And now Jenine is going to lead us through an example in each of work that we've done over the last decade, I'd say, in each of these steps of the research process.
Thank you, Saskia, for setting me up. So I'm going to apologize in advance. I'm just getting over a little cold, so I have a frog in my throat. So apologize for the throat clearing. But I'll go through as best I can. So as we go through each of these steps, we're going to try to demonstrate how actual research teams have done the process of knowledge translation or community engagement in these ways. I'm going to start off with identifying and prioritizing. And as Saskia said, there has been a shift in research to do more and more of involving the voices of communities in identifying and prioritizing research topics. One example we're going to give here is the James Lind Alliance, which is actually an international initiative that's aimed at doing priority setting partnership, which is involving people with lived experience, clinicians, and community members in deciding the priorities for a specific research topic. So the example we have here is around neurodevelopmental disorders in research. And they did a process where, led by a very well-informed facilitator, they went through a rigorous process of whittling down 1,200 questions that were provided by the public that they thought should be priorities for neurodevelopmental research into a top 10, which you see here in this infographic, which are the priorities that they feel need to be researched around neurodevelopmental disorders. The James Lind Alliance is actually a very cool initiative. They have top 10s for all kinds of disorders and areas around research. So if you are curious, they might actually have some priorities that are related to the work that you're doing that you can either pick up or work alongside. On a more maybe manageable or smaller scale, an example we have is the iNeuron project, which is a research team that received an NFRF grant to do work around gene therapies in neurons. They had kind of a general idea of what kind of research they were going to do, but they wanted to do a more lived experience prioritization process. So they worked with their lived experience advisory council to refine what specific research questions were of priorities to people who had lived experience of neurodegenerative disorders, and that's going to guide their work over the next couple of years. At the research design phase, you can work with people with lived experience, policymakers, or stakeholders to think through the methodology that you're going to be doing in your project. One of the examples that we have for doing that is a project that was led out of researchers at the McMaster University around children with incarcerated parents. So looking at kids whose parents were incarcerated at some point in their childhood. They partnered in this project with the Canadian Coalition of Children with Incarcerated Parents, which is a collection of nonprofits who are interested in supporting these children, to talk through their research design for this project to understand what specific data they should be looking at and where they should look for that data. So this study was looking at, what should we think about when we're thinking about children with incarcerated parents? And this community group that they worked with specifically said that they have no number of children who had experienced incarceration in Canada. So that was kind of the key information that they were looking for that would help them advocate for funding and resources for this community. So working with them, they came up with, I've redacted the numbers here just for, since this is still in manuscript form, but what was the number of children who experienced incarceration in the provinces of relevance, and then in which years? And then what is that rate? So 2 to 3% of children under the age 18 experience incarceration in these provinces. So working with their partners, they could design the research to be as relevant as possible to those who'd be using the findings. We get questions around grants and funding applications a lot, and how to include knowledge translation and or community engagement in grants and funding applications. We know that it's very challenging, especially since the rate of funding is different depending on the grant or what the study is, and not every project that's put in for a grant gets funded. So we're going to give you kind of an example of like a really high level of involvement, and then also potentially what you could do if you don't necessarily know if you're going to be funded. So the example we have here is for a research team who was putting together the Prison Health Council, which is a council of people with lived experience of incarceration. They wanted to put together a grant where they were getting funding to create this council, and the council would then be people with lived experience advising the Department for Family Medicine. Um, as they were creating that grant, they thought it was pertinent to bring in a community investigator as a partner in the grant development process. And that person then guided them on how to make sure that they were well representing people with lived experience of incarceration, and that they were including the necessary things to respect their values and their rights as they were creating this council. The community investigator themselves was a person with lived experience, so they were right in the grant process, figuring out how that grant would best represent their values. So at the top end, you can kind of include stakeholders, whether that's policymakers or patients or family or community members, right from that prioritization design that we mentioned, and then they're involved in that grant right from the get-go. If that's not possible, you could work on that KT plan section. Most grants now have a knowledge translation plan included, and a lot of the time we kind of stick to the same, we are going to be in a conference, we're going to do a poster session, or, we'll maybe do some great literature. But if you take a little bit more time and like flesh out what your integrated KT plan could look like, who you could potentially work with, whether that's having 1 or 2 patient advisors or involving a policymaker at some point in the process, you can add a lot more to that KT space, and then potentially that will like make your grant a little bit more robust. Then if you do get that grant and you do have funding, then you can act good on that collaboration that you've described there. At the data collection phase, we have an example here about how research protocol was actually adapted with the involvement of patient advisors. So this is about a project that was done at the Sunnybrook Hospital that was based on dementia research, and they had a series of assessments that they had people with lived experience of dementia doing as part of this research project to collect data. But they didn't really think through what it was like for people with lived experience of dementia to go through a hospital that they didn't really know how to wayfind around, or how to get to each of their assessments. And they found that the data collection process was either incomplete, or people weren't getting through all of the things that they needed to do. So working with their patient advisory committee, they redesigned that research protocol so that the patients could either do their assessments over a series of days, or have someone guide them through the hospital, so that the data collection process was more amenable to people who didn't really know their way around a research space. At the data analysis and interpretation phase, Saskia alluded to this before, and this is a way to involve stakeholders in providing different context to the numbers than just what the data are telling you. So this is an example that we did with a research team at McMaster around incarceration and opioid use, which was a very heavy and important topic, thinking about how those who use opioids, what happens to them after they are incarcerated, and the rate of death that actually happens once they leave their incarcerated facilities. So we worked with a group of people with lived experience of both incarceration and opioid use to analyze this data. So they were given kind of the raw numbers, and they were asked to interpret it based on their own experiences. So for example, in this slide here, you see that they have the characteristics of the people who died with an incarceration history. And one of the things that they pointed out is, in that second bullet point, it states that 9% of Indigenous and 7% of Black individuals were those who had died after incarceration from opioid use. And the community members did mention that there is actually a very high rate of incarceration of these two populations, but the numbers were showing very differently from what they expected to see in their experience in the community. And part of the reason they thought that might be is because often in incarcerated settings, race data is self-report, and these communities feel very unsafe reporting their race when speaking with law enforcement. So that could result in a misinterpretation of why the data doesn't represent what they see in community. I'm also going to flag here on a few of these slides, we have some QR codes to show links to some of the information if that's of help, that is helpful to you. We are also going to be sharing a PDF of the slides after, so you can get access to some of these things if you want to look into it more deeply. Okay, and this is probably, as Saskia said, the place that most folks are comfortable with understanding how knowledge translation can take place, and that's at the dissemination, or often called end of grant knowledge translation space. This is an example. I embarrassingly was in this series of videos, so there's a picture of me there. But this is an example that I did when we were working at ICES, and we had a whole bunch of very cool research happening, but it wasn't really amenable or shareable to the public in a format that they thought was easy for them to digest. So at the time, our public advisory committee had advised us on creating some videos, which we then called the More Than Numbers series, that took the data out from the research and into a space that was more accessible to people who weren't in research. There was a few videos done. One was on the COVID-19 pandemic and how they used public health data to understand vaccination rates and positive and negative testing rates. You can see our cadre of very amazing researchers on the side, right beside me in that video, talking through in a public-friendly way how that research was done, what data they used, and also how it was used to make information for policy change. There's also a data research on mental health data, and there's one on immigration data if you're of interest. So videos are an example of a dissemination process. There's infographics, lots of amenable media out there. Some researchers use TikTok now, YouTube. There's so many different ways to kind of get your findings out there and push the boundaries a bit on end of grant KT. And then lastly, here's an example of an implementation and evaluation space where research was taken out of the academic space, out of the journals, and used to apply to both a clinical guideline and then a patient guideline. So the Choice D guidelines were created by CanBind, which is a depression research program in partnership with the Mood Disorders Association of Ontario. And this project was funded by the Ontario Brain Institute. And what they did was they took a very technical, very clinical focused guideline that was built off of academic research. And that was meant to guide clinicians on how to treat depression. And working with people with lived experience, they adapted that guideline to the Choice D guidelines so that patients and families could advocate for themselves for what their standard of care should be and what their care preferences was. One of the really cool examples that came out of this was that the researchers found that like when prescribed antidepressants and antidepressant medication, often patients didn't know that they had a choice in what kind of depression medication they were given, and they all have side effects. So being able to understand, like, this depression medication causes weight gain, but it can help you with these issues, or this anxiety medication has these specific potential side effects, is just empowering enough to help patients guide through their care pathway a little bit better. Okay, so one of the things we said we would talk about was how to do engagement meaningfully. We understand, that the word meaningful has a lot of meanings. So we were going to talk through a little bit about what you can actually do to think through tactfully how to make that engagement that you're doing really deep and really meaningful. And through that, we're going to go through some of the areas that we get asked about a lot. So the first one is including diverse audiences. We all know and we all strive usually to include people from diverse backgrounds, whether it's racial, economic, education levels, in our work to really represent the voices of the people that we're including in our research. But that is really challenging. And so we try to give people some helpful tips to figure out how to make sure that you get those diverse audiences when you're doing your work in KT. The first that we always say is that your call has to be inclusive. This is an example of a call we did for the Canadian Brain Research Strategy. As you can see, it's very bright and colorful. It has a very clear call to action, shape the future of brain research in Canada. And it even says in that green box, we are looking for diverse voices across age, geography, race, gender, and experience. It's really challenging for people to see themselves sometimes in these research calls to understand what their expectations would be. So we try to be as clear as we can, who can participate, what you're receiving, what we're asking of you, and then they know that whether or not that aligns with what they can bring to the table. Then you need to share that call in spaces where those people reside or gather. So we exist in the research and academic space. We're on LinkedIn, we're in conferences, we're at places like that, but that's not often where the audiences that you want to engage in this work are. So policy spaces, community spaces, religious spaces, thinking about where those people actually are. Sometimes that means sharing something on, social media, and that's where they reside, or working with, as point three says, building relationships with partners or communities that represent those diverse audiences and that have trusted relationships with them. So, for example, if you're working with an LGBTQ plus community, what is a trusted partner that you can build a relationship with that already has those individuals involved in their work, that you can lean on them to involve. People are often very readily interested in supporting and providing their input into research work. You just need to get them the opportunity. Once you hear back from those people, you need to put them into a space that is inclusive and safe for them to be involved. That means moving outside of our ivory towers and research centers and into the community spaces. That could mean hosting at a library or a community center. Sometimes it means a coffee shop, depending on who you're working with, or a school. I know a lot of you are doing work with children and families. And that's just more comfortable level playing field for everybody to be involved. We also talk about time. We like to do our work during the working hours, but so does everybody else. So we often tell people that if you really want to be inclusive, have your sessions in the evening, have them online if that's easier, or sometimes on the weekends. And that will be the place where people can actually spend their time. And I'm going to talk about this number five a little bit more later, but compensate people for their expertise and time. They're giving a lot of themselves, their experience, their thoughts, their stories to you, and their time to you. And compensation is absolutely important to ensure that you have diverse audiences at the table. Saskia and I have had the privilege of working with many Indigenous communities across Turtle Island in our time in engagement, and we are also very grateful for the lessons that they have taught us as we've been doing this work. So we wanted to pass on some of those lessons to you, specifically around working with Indigenous communities. These are the ones that we have learned. There are so many more things to learn, but we just thought we would share what we know. Firstly, whenever working with Indigenous communities, you need to reflect on your positionality and role in colonialism and how your work reflects those things. It is, very pertinent that you think about how you are involved in this system whenever you are stepping into the space where Indigenous communities are. Building relationships here is absolutely key, and building them before you start doing work. As point three says, this research needs to be mutually beneficial, so relationships are a very important part of that. Historically, Indigenous communities have been the subject of research that has not helped or supported their communities in any way and has been very extractive, and we have learned this from them in many ways. So that research that you're doing needs to have some kind of benefit to their community, and hopefully, in best case scenario, is built with them. Understand the unique history of the communities that you're working with. We often lump together First Nations, Inuit, Métis. Even within First Nations, every nation has their own governance structure, leadership structure, their own culture and history. And when you're doing your work, it is very important for you to do that education for yourself to understand the unique histories of the communities you're working with. As you're doing your work as well, respecting indigenous ways of knowing and doing and applying them where relevant, working with the elders in the community that you're working with to understand how your research can best represent their values. And then some tools from the research space, applying the OCAP principles. That's the image of the OCAP principle logo there. Ownership, control, access, and possession. If you're not familiar with OCAP principles, they're around guiding research on First Nations communities. And then looking into understanding how you can support Indigenous data sovereignty. So the First Nations Information Governance Center has lots of resources and tools for how they do work related to supporting Indigenous data sovereignty. There's also the CARE principles, which are created by Indigenous researchers to support work done in research to improve Indigenous data sovereignty. So hopefully that kickstarts you on a learning journey of your own if you plan to work with Indigenous communities. In both of those last two examples, I mentioned building relationships. If you're doing people work like we're talking about here in knowledge translation, whether it's with policymakers or with people with lived experience, building relationships is a huge part of it. And I'll be honest, building relationships in research is not that different to doing it in every other part of your life. You just kind of have to take the time. So firstly, reciprocity. Research from our side, often we're thinking about what we're doing, what we can get out of it, but we also have to think about it, what's in it for them. Sometimes that's just getting better knowledge about the work, the disease or disorder that they're experiencing. It's helping clinical outcomes or clinical trials. It could be helping someone else who has that experience in the future or changing policy. Thinking that through really helps making sure that this is a transaction. This is like a two-way street and not just that there's reciprocal care taken into your KT process. And that, of course, takes time. So often we're like rushing to get these relationships out the door, trying to make sure we're hitting these grant timelines and things like that. But it takes time to build true relationships with people. So be proactive. If you're working in a space, start building those relationships now. If you're working in education, nutrition, things like that, figure out who the key players are and start building those relationships. So when time comes to do that work, they're already in place. And then create a level of understanding. Often we think about explaining research to people. They don't understand the research process. We need to explain the research process, but they also have knowledge that you don't know. They live whatever it is that you're talking about every single day, whether it's the community that they're in or the experiences that they're having. So you have to take time to create a level of understanding with them around research, and they also need to have the opportunity to provide you with information about what their life experiences are like. And then you need to respect that knowledge. We all bring different types of knowledge to these conversations. So, just because we're coming from an academic space, it doesn't mean that those people don't have very valuable knowledge in other areas that can be applied to the research as well. And then lastly, building trust. Trust can look so many different ways. It can be rebuilding trust if those relationships have been broken. It can be consistency. It can be transparency. That really depends on who you're talking to and who you're working with. But again, it's very similar to the trust that you build in every other aspect of your life. It just takes time. Okay, and lastly, I'm just going to dive into compensating lived experience partners, as I mentioned. Compensation has been a topic in knowledge translation for the last 10 to 15 years, and now it has, I'm glad to say, become best practice to compensate lived experience partners who are working with you in your work. We know that that's not always the easiest thing to do for lots of reasons, but what is the most important thing is that you're transparent around what type of compensation you're providing them and the amount that you're giving them. That means if it's a gift card for $5 to Tim Hortons, that when you're bringing people in to be involved, you are very clear on what that is. Or if it's a $250, stipend to be involved in a half-day workshop, you're clear about what that is. Not every institute, but many institutes have approaches that they are baking into their processes now for how to do that. I know CAMH has this whole gift card structure that they provide for all of their research participants and lived experience partners. Your institute might have one. I know CIHR has kind of been pushing down, and the SPORE support units have been pushing down to create structures because it is challenging sometimes around institute approaches to get through some of the financial difficulties related to compensation. But check in with your institute. They often do have some kind of structure for compensating lived experience partners. Currently, as far as I can tell, the rate is approximately $30 to $40 Canadian per hour for lived experience partners. That is an approximate rate. Sometimes it is better to compensate people for days or amounts of work, but it can help you ballpark how much you might need to provide. What's great about that is it helps you bake it into your grant. Like as we were talking about earlier, if you are planning to do knowledge translation in your grant, you can bake that value right into your grant, including your compensation there, and then it doesn't become a surprise later on when you're trying to scrap for money to figure out how you're going to pay your lived experience partners. And I've also added a list here of helpful guides that have been updated in the last few years around rates. They include things like who should be compensated, how you can compensate them, whether it's gift cards, stipends, things like that. Through CIHR, the Sport Evidence Alliance, I think, did a systematic review, Child Bright, and Diabetes Action Canada. These ones have been built in the system, and they also are often built with patient partners involved, so they have lots of great, valuable thoughts and feedback there. So that's our last slide on how to do meaningful engagement. That was a lot of information, but hopefully some helpful inspiration to tickle your brain as you're working in this space or planning to work in this space. So we just want to say thank you so much for coming to join us today. And what questions do you have for us? Feel free to raise your hand. You can drop them in the chat, and Saskia and I will answer them to the best of our ability.
Perfect. Thanks so much, Saskia and Jenine, for such a great presentation. And yes, to follow on what you just stated, for those who are interested in posing a question to our speakers today, please feel free to raise your virtual hands or to enter your questions into the chat. Certainly keep an eye on the chat to make sure those questions are raised to our speakers for today. You can also separately reach out to them with your questions in the event nothing has struck you yet with the relevance of this topic in relation to the work you're leading. But perhaps to get things started, I might pose a question to our speakers just to get the juices flowing. Jenine, Saskia, please feel free to decide amongst yourselves who would like to go first in answering the question. But on the note of budgeting, which I think is on the minds of a lot of people on this call's mind with respect to their work, how do you advise people consider budgeting for engagement or knowledge translation activities in their grant proposals? What has your experience been, and what sort of words of encouragement or advice you could give those here today?
Janine, do you want to take this one? It kind of touches on the grant stuff.
Yeah, sure. I think the easy, so are you asking like how much? How much you would, okay,
Yeah, like how you would weigh that, with
I could weigh
respect
that.
to the ask of what you're intending to, engage patient, family, community partners in the work.
I would say, like, I think, okay, so obviously I just talked about compensation. So that's like the first stage, thinking through. There's lots of helpful tools around KT plans, and you can think through like, okay, let's say we decided all we can really afford is to bring in two patient advisors for a couple of hours. Like you can start small and, think about compensation, and that's kind of your main, budget or whatever your KT tool is, pricing out like an infographic and getting a graphic designer to do it or getting your local communications team at your research institute to do it. It doesn't have to be a $10,000, you know, engagement process to start. And you can start small with like a couple hundred to $1,000 in your grant. And then by including that in your process, you really, well, one, if you get your grant, you've already committed to it, which is great. And then you have the funding committed and you don't have to worry about tacking it on and removing, funding from other areas of your project. Um, but yeah, I think that like when it comes to lived experience partners, thinking through, if there's event planning, costing, compensation, and any other like small logistics. But you can start small. And then if it comes to like KT products, you can think through, and you can probably Google these things like, if it's a video, it might be a little bit more money because you need someone to produce it, or if you want to produce it yourself, that's also cool. And pricing that out and then including that as you write your grant. Does that sort of help, Priscilla? Yeah.
Yeah, I think that's a great starting point for
Saskia.
folks on the call to consider how it relates to some of the decision making that they're having to ensue or conversations they're having with advisors or research teams about how to do this work, as you said, in meaningful ways,
Hmm.
especially around the budgetary piece. It also sparks for me another question. Sorry,
Yep.
I don't want to take over by any means. So again, for those on the call, please feel free to raise your hands at any point or to write your questions in the chat. Um, I was just thinking along the lines of budgeting and building relationships. As we know, just thinking about CIHR, there are time-pointed periods in a year in which we're submitting these applications and working towards building these relations to a level of strength where an individual may feel comfortable taking a position on the grant, contributing in certain ways. But what happens in the in-between? You submit your CIHR application, say October 2025, but you're not necessarily going to hear until spring 2026. What would your advice or words of encouragement be to those on the call of the in-between around building and sustaining those relations in the interim to keep that momentum going?
Yeah, I think communication is key, open two-way communication. Often we think when we have nothing to share, there's no point in communicating, but I think that's the biggest pitfall. Communicating that you haven't heard a response yet is communication. So I think it's maintaining those relationships and managing the expectations. And I think sometimes researchers are scared that people with lived experience, patient partners, will get frustrated with the timelines of research that often, they're slower than maybe other types of timelines of work. But I think if there's a shared understanding of what's the expectations of this project, we're expecting to hear in the spring, but again, sometimes we don't. I think all of that comes down to communication, comes down to maintaining an open relationship with the patient partners that you work with and you want to bring in. And I think you'll see that they're very understanding of not everything works out perfect, and sometimes they do work out and sometimes they don't, but they appreciate being involved and communicated with, and then, understanding that there may be other opportunities, even though this grant opportunity is or is not successful. So yeah, the communication is key, I think.
Great words of encouragement. I love the emphasis on communication is key as a lesson for everyone here
For
today.
everything in life, I think.
Yeah, I think so.
Inclusive of research, yeah.
We have a few questions trickling in the chat. The first comes from Carolyn. So Carolyn says, I'm wondering if you could clarify exactly what co-design, co-development, co-production are, which I think is a great question. And how do these fit into the public patient engagement model?
That is a great question. I love Saskia chime in too. Sorry, my throat's doing that thingy. But I find it so tricky in this space. There's so much terminology. And like, even in like knowledge translation, there's knowledge mobilization, there's all these things. So co-design, co-development, and co-production are probably all very similar, maybe just at different stages. Um, so maybe we'll talk about co-design a little bit. And co-design is essentially Saskia showed that IAP2 spectrum, and it's kind of like the empower level. It's like literally working directly and collaborating thoroughly with uh, an external stakeholder to design everything. So their expertise is involved in shaping everything. So a lot of what we described here, where you're like developing and identifying priorities or designing a research process, and they're kind of with you all along the way, that would be a co-design an example of a co-design. But you can do co-design in any kind of process. It doesn't have to be research only. You can do it in like writing. You can do it. So I think it's a term that spans across different domains. And so in research, kind of patient engagement, deep patient engagement, or like integrated knowledge translation can essentially be a co-design process. Does that make sense, Saskia? Did I explain that well? Do you have anything to add?
Yeah, there are all these terminologies that are overlapping, and I think we often say co-design is the it's like the clinical trial best practice when it comes to patient engagement, and it's not always feasible, but if you can co-design, we recommend it. But again, it takes some budget, it takes some relationships that you already have, it takes some planning. And so, as Jenine said, you can start small. It doesn't have to be this full-on co-designed project, but co-design is a nice standard to aim for.
Yeah. Yeah. So I think I think the co-design term comes from the design space, like product design, marketing, things like that, where they would bring in like literally a group of people to design something with them. So in research, doing integrated KT is doing that, bringing in people with lived experience or whatever stakeholders to design your research with you. Hopefully it's a clarifying. We got a
And
couple
then co-development and co-production would be more the development. I think that refers more to the dissemination phase of engagement and knowledge translation, where you're developing in partnership, or you're producing in partnership with a patient partner, typically some sort of knowledge translation project, whether it's a video, an infographic, a guideline. So again, referring to collaboration, but I think those words refer more to the development of products than maybe the research process as a whole.
Awesome.
Perfect. Carolyn, I hope that was clarifying enough for you. Please feel free to chime in if there's a subsection of that you'd like expanded upon. I'll move on to the next question from Vicky. Are there particular characteristics that you look for in a good partner to collaborate on a research project?
That's such a good question. I don't know if I've ever put together a list of characteristics for a good partner, but I think the first things that come to mind are just interest and curiosity for the topic, for the research, for the project, even if they're not necessarily well-versed in the research world. And then, that they can be a good team member and good collaborative person, because you're really trying to build a collaborative environment. But I think beyond those, what happens in this space sometimes is you'll have a few people who've become patient partners on everything, and they've been elevated to this like professional patient partner, title, and they get tapped on over and over again because they now know what to do and they know what's expected. And we really try and push people away from that. And there's so many other people that are willing to be involved who might not know a lot about research, but that's okay, because that's not the easiest thing to learn, but it's something that you can easily catch someone up to speed on. Whereas things like being collaborative and being genuinely interested and curious and wanting to see value come from research, I think when you have those core characteristics, you can bring someone up to speed on the details and nuances of research pretty quickly, if you have those soft skills.
Yeah. I don't have anything to add to that. Great question. Great answer, Saskia.
Thanks, Vicky, for that
It's
heart
good though.
emoji.
I
It's
don't
a
know.
really good question.
It's a very
One
good
tool I might
question.
suggest that not actually about the characteristics of the individual, but one tool that I found helpful when thinking about the characteristics of your collective group is creating this thing. I call it a dream team. So often when we make like patient advisory councils or groups of people, like focus groups, we don't know, we're like whoever comes in the door we're going to select them. So if you articulate your goals, like we want 6 people who are in this age bracket, we want this many racial groups represented, we want this many whatever, it seems a bit tokenistic, but it helps you aim for those goals. So if you are missing representation, your dream team can help you guide to where you need to put those diverse calls out. So that's a bit different than the individual characteristics, but it might be a helpful way to think through who you need to get in your spaces.
I think
Um,
this also segues really nicely to the next question around measuring the impact of success of your KT or community engagement efforts.
Mm.
Do you go back to the community to try and engage them, and how do you interpret their real experiences? Like, I think this is also like a good question to pose and consider.
Yeah,
Yeah.
this is ongoing development, ongoing discussions, ongoing. I think there's a lot of uncertainty in this, but it's very important to do. I don't think everyone's figured out exactly how to do it. Immediately after you engage patients, partners, community, there are some tools now developed to help you evaluate the the engagement that was currently happened. So how I'll actually, yeah, I just found it. There's a whole tool and it shows you, it has questions to evaluate how people felt in the session. Did they feel heard? Did they feel valued? Do they feel like the the feedback and the work is actually going to move forward and make a difference? So the link I posted is from McMaster and it's called the PET, I think is the acronym,
PPT,
but
yeah.
yeah. So it's a
Gillian
public and patient
Eggleston's tool.
engagement evaluation tool. And so they've developed like a very robust evaluation measure to be able to measure some of this stuff. So you can take a look at that and just see a sense of what kind of questions are people asking and what you're trying to measure. But you're really trying to look for if people felt heard, if they felt like they could contribute, if they felt that they feel confident that what they heard, what they shared is going to be used and actually make a difference in the research. Things like that get measured with surveys and evaluation tools. But then the actual like implementation sometimes of the KT, that's even trickier. So you'll come up with an evaluation plan. Let's say you have an infographic, and then you'll come up with some measures that, you want to see how many times the infographic was downloaded, or you want to see how many partners reshared your infographic, or you want to see there's certain measures and metrics you can come up with ahead of time to try your best to determine if it's having an impact. But again, this is the evaluation world is it's tricky and there's short-term goals and then there's longer-term goals, right? Did the infographic change anyone's behavior when it comes to, diabetes and healthy habits? That would take a lot of another whole evaluation project to see if a certain tool or product actually changed some behavior long term. And that's a whole other evaluation project that you can do and just, plan it out and do it.
A great question
These
to
are really
pose,
great
though.
questions, guys.
Yeah, I want to say a really great question to pose because often these things are left out of those initial stages of planning, like evaluation of engagement. And the Pete tool from McMaster is like such a great tool. I encourage those to deep dive a little bit further if this is something you're entertaining and weaving into your work. There are obviously other tools in this field that are in development, but the Pete just lays itself out really nicely and succinctly at which particular time points you can consider in the research trajectory of weaving in particular questions and ways of launching evaluation as a survey or as a focus group. So please feel free to poke a little bit more around that link. I encourage you to do so.
Um,
Um,
I'm
Emily
just
had
going
a
to follow
very
up on that. That Emily you just shared, like combining that academic rigor with combined and real experiences. There's actually been some really great literature that's come out recently about how to include people with lived experiences feedback in the academic papers that you're writing. The opioid project that I mentioned earlier, actually, when they did their final manuscript, it included that context that they had added to the analysis. And there's a lot because people are doing this more and more. There's actually some great guides out there. So take a look at including, I don't have a link handy, unfortunately, but including how to include lived experience feedback in your academic literature. And then you can kind of merge the worlds a little bit.
Yeah. They
Yeah.
don't necessarily have to be they seem at odds with each other, but I think they really don't have to be at odds with each other. There's room and place for each within a research project. You always need to interpret the data after, and there's no one way to interpret the findings. So I think researchers put their human experience into research, and so there is a lot of space for people with lived experience also to put their human experience into rigorous academic and research practices.
This has been such a great conversation. I don't want to lose sight of an additional question we have here in the chat from Shelby. If we are using a more broad definition of community engagement, could you please explain further how community engagement would differ from stakeholder engagement?
Oh man, the terminology is so tricky. Um,
It doesn't.
it doesn't really. I think sometimes stakeholders literally mean people who have a stake in the work. So that could be like policymakers or, other academics, or it could be
Clinicians,
broader. Usually community is more like people who are impacted by the work, like individuals, neighborhoods. Like typically it doesn't include professionals, but it can. Like as we said, if you're doing work, if some of your research has something to do with teachers, for example, teachers could be considered the community of interest. It doesn't differ that much. I think stakeholder is like, we talked about like patient and then there's community. I think stakeholder is like even broader than that. And it just is like literally anybody who could have a stake in this work in any way, right? Which could include like literally anybody. So often they're used interchangeably. I think you're just getting more and more refined in the people you're talking about as you're talking about your engagement. I hope that helps.
but we tend to use it a bit interchangeably.
Yeah,
Patient, community, and stakeholder,
yeah,
it's all people, yeah, that have a stake in it, that are impacted by it,
yeah.
and that you should be speaking to and involving.
I will say the word stakeholder is very not lay friendly. Like people who don't work in this space have no idea what a stakeholder is. So use that to your own discretion as you're describing who you're talking to. Um, okay. Is there anything else that
I'm
we
just
missed?
catching up. I think that's it. We're also close to time. Um, oh, perfect. Thank you, Shelby, for chiming in and just acknowledging that we've covered your question appropriately. Um, we're at time. So I do want to thank everyone for such a great conversation today. I always look forward to these monthly meetings where we can chat a little bit more with the speakers on a specific topic and really dig our heels a little bit deeper into a specific area of focus, a topic, a case example. So thanks everyone for joining us today, for contributing to the conversation. Certainly look forward to the next one. We're in the midst of planning for November, so please keep your eyes peeled for those promotions once they're released. But I'd like to take a moment again and thanking both of our speakers for joining us in this session, for sharing their expertise, their knowledge on this topic with us, and for engaging in such an incredible conversation with the group. And again, thanks to those for joining us. I look forward to seeing you at our next event and wish you all a wonderful day as well as weekend. Thanks. Bye, everyone.
Thank you so much for
Thank
joining.
you.
Nice